Good afternoon and welcome to the FEMA Region 2 Individual and Community Preparedness webinar series. My name is Allison Albright and I'm the Regional Preparedness Liaison for FEMA Region 2. I'm going to provide a few technical considerations before we begin. Today's proceedings are being recorded and captioned. The archived event will be available on the FEMA Region 2 website in the coming days. You should hear audio through your computer speakers, so please ensure your volume is turned up so you may hear the proceedings accordingly. In the top right corner, we ask if you'd like to receive news and updates from Region 2, and if so, please enter your email address and we'll be sure to add you to the distribution list. We will have a question and answer session after the presentation concludes. You'll see a Q&A pod in the lower right-hand corner. Please feel free to submit your questions about the subject matter there, and time permitting, we'll do our best to answer them. Finally, the PowerPoint presentation from today will be available for you to download in the file share pod as a PDF. You can click on the file and download it using the download button. With that, I'd like to turn it over to the Region 2 Community Preparedness Officer to introduce our speaker and today's proceedings.
Good afternoon, everyone. I'm Debbie Costa, the Community Preparedness Officer for FEMA Region 2. On behalf of our team working to strengthen preparedness across New York, New Jersey, Puerto Rico, and the Virgin Islands, I'm thrilled to welcome you to our Preparedness webinar series. In FEMA's 4-year strategic plan, the agency's goal 1 is to build a culture of preparedness. The Region 2 Individual and Community Preparedness Program is focused on preparing individuals and communities for disasters by providing useful information and training, inspiring people to take action and be ready for any emergency. As part of that goal, we're pleased to be hosting today's webinar in partnership with the U.S. Department of Health and Human Services and U.S. Department of Veterans Affairs Office of Connect Care. This webinar will provide an overview of telehealth and how the Veterans Administration has incorporated this into their services. This webinar will also provide information for health systems and individuals on integrating virtual care into their own disaster contingency plan. Our first speaker today is Lori Graff. She is the Telehealth Emergency Management Program Manager for the U.S. Department of Veterans Affairs Office of Connected Care. She is a registered nurse with a Master of Business Administration and a Master of Science in Information Systems Management from Duquesne University. Lori has been with the Veterans Health Administration since July of 2011. Prior to joining the VA, she spent over a decade as a medical management consultant working with health plans to improve clinical quality and cost effectiveness of care. She has clinical experience in both inpatient and outpatient care across the continuum of care. Our second speaker today, William England, is Senior Advisor for Telehealth in the Federal Office of Rural Health Policy at Health Resources and Services Administration. He was Director of the HRSA Office of the Advancement of for Telehealth. He began work in healthcare financing as an assistant professor of industrial engineering at the University of Wisconsin, and then came to CMS where he ran the first Medicare telemedicine demonstration. Subsequently, he became Director and Vice President of the FCC Universal Service Rural Healthcare Program before coming to HRSA. He is a Fellow of the American Telemedicine Association and was a Robert Wood Johnson Foundation Healthcare Financing Fellow. He has a BS and MS in Electrical Engineering and a PhD in Industrial Engineering from Purdue University and a law degree from the University of Maryland. Thank you, everyone. Welcome. Lori, I will hand the mic over to you now.
Thank you, Debbie, and thanks for this opportunity to share about telehealth for disaster preparedness. Before we dive into today's webinar, I just want to pause to remember that our freedom isn't guaranteed, and I want to thank the veterans of all branches. So to all those who have served, those who continue to serve, a belated Happy Veterans Day. Thank you, veterans, for your service, your sacrifice, and your bravery. Right in, today we're going to cover 4 key things. We'll talk about what we mean when we use the term telehealth. I'll describe VA's telehealth services and how telehealth has been used so far in the pandemic response. we'll talk about the importance of integrating virtual care and telehealth into disaster preparedness at all levels. And then I'll turn it over to Bill England with Health and Human Services to provide an overview of telehealth in his organization. So on to the overview of telehealth. You may have heard some of the many terms that are often used interchangeably with telehealth, such as telemedicine or virtual care. And because this is such a rapidly evolving field, and these terms don't always have consistent definitions, I want to spend just a minute talking a little bit about how we define telehealth and what we mean in context of this webinar. So in the VA, we define telehealth as the use of electronic information or telecommunications technologies to support clinical health care, patient and professional health-related education, public health, and health administration at a distance. So broadly, telehealth can be defined as the delivery of healthcare services through telecommunications technologies such as cell phones or computers. So when we think about the telehealth experience and what is needed to have an optimal telehealth experience, there are both technical and people skill requirements. On the technology side, at minimum, there has to be access on both sides to a secure broadband internet connection and some sort of a device with a camera and microphone that will help to connect the two. So that might be a smartphone, a tablet, a laptop, or a computer with a camera. So those are the fundamentals that are needed on the technology side. On the people side, both clinicians and patients need to have a basic understanding of how to connect. Patients should treat a telehealth visit the way they do a regular office visit, prepare for it in the same way. Providers have to have additional training on top of their clinical training to make sure that they provide a good experience for the patient in the telehealth visit. And that includes things like how to handle emergencies that may come up, how to make sure that you're dressed appropriately, that you have good lighting, and that you look at the camera and other basics that make it a better experience for the patient on the other end. So with those basics in place, telehealth really can bring care to where the patient is, and this includes increasing access to care that may not otherwise be available, and in a way to improve patient satisfaction, especially with those rural veterans that and patients that may have to drive miles to a visit. So telehealth can be delivered in many different ways. So some of the most common ways are live video conferencing, or also called synchronous telehealth, because this is a two-way audiovisual link between healthcare providers and a patient. And this can occur in many different places, whether it or even between two providers. So it's that live video conferencing is the modality most people think of when they think of telehealth. But there are other ones. So store and forward telehealth, also known as asynchronous telehealth, is the use of technology to securely acquire and store clinical information that is then securely forwarded to or retrieved by a provider at a different time and place for a clinical evaluation. Remote patient monitoring is a tool that turned out to be very important during this pandemic. It's the use of electronic devices to record patients' health data in home and with mobile monitoring. Also has messaging and video technologies. So it's basically that, as the name implies, a way to remotely monitor patients. mHealth refers to those health-related applications and programs that are typically used on mobile phones and other smart devices. So, for example, this may include text messages or phone applications that help patients manage their blood pressure and cholesterol levels, other things like that. And then there's the good old telephone, audio only. And this is the use of either a landline or a mobile phone to connect a patient and provider. So there are many different ways to utilize telehealth, depending on what the need is at the time and also what the patient has available to them at the time. So let's talk now a little bit about how VA's telehealth services are used to improve the access to care and quality of care, and specifically how we use those modalities. So the VA, the Veterans Health Administration, is the nation's largest healthcare system, caring for over 6 million veterans in 18 networks, 170 medical centers across the country. So the VA has been an early adopter of telehealth services and has over 15 years of experience with telehealth. Our vision is that we will leverage the connected technologies to enhance the accessibility, capacity, quality, and experience of VA healthcare for veterans, their families, and their caregivers anywhere in the country. So this vision is really part of a wider vision of having connected patients, that of VA clinicians staying connected with what veterans want for their health care and how to best meet the veterans' needs for where they are. And this has resulted in the VA's high levels of patient satisfaction and positive clinical outcomes. So looking at all those different modalities, these are all ways that telehealth can make sure that veterans have access to care when and where they need it, whether it's at a VA facility, in the patient's home, or wherever they are. So that may be including being evacuated to a motel room and they're calling for help because they've been impacted by a disaster. So these technologies on any device make it easier for veterans to connect with their VA healthcare team and to deliver the right care at the right time in the right place. When we look kind of at the big picture of VA's types of healthcare services that we have, we use a wide variety of technologies to make sure that we have excellence in care delivery and are able to deliver exactly what the patient needs at that time. So the suite of tools that are kind of hard to see in the little micro icons, but that suite of tools work together to make sure we deliver the right care at the right time in the right place. So that includes the video teleconferencing, we call VA Video Connect. There is a portal that is secure where veterans can utilize called MyHealthyVet. There's RX refill applications. There's applications like Annie that helps with text messaging and other automated reminders. And then there's home telehealth or a remote patient monitoring. And I'll talk a little bit about each one of them now. So our video teleconferencing is called VA Video Connect. And this is where veterans meet providers in a virtual medical room using a camera on their smartphone or tablet or computer at home. And they're basically having their visit with their provider through in this virtual medical room instead of having to drive all the way in, find parking, get to their appointment, wait in the waiting room, all that jazz. So VA Video Connect really does help veterans and providers work together to make sure that, first of all, that the visit is appropriate for telehealth and doesn't need to have that hands-on care. And so working together, we can help to give exactly what the veteran needs at that moment in time. So how this works, and as you can see on the screen, we have a couple of physicians here, and the way that VA Video Connect works is first the veteran would talk to their doctor about whether or not it's appropriate for that time for their care plan. And then the veteran is sent an email link, or now they can also be sent a text message link for the VA Video Connect session once it's scheduled. And then at the time of the appointment, the veteran just clicks on that link, enters their information, and launches the session, and they're in, and they're talking with their provider. So very simple and basic, but it's a big foundation of how we provide care. So looking at store and forward telehealth, these are the technologies used to securely acquire and store clinical information that's then securely forwarded or retrieved by a provider at a different time for a clinical evaluation. And this may include capturing images like we might do in teledermatology to take a picture of a patient's skin lesion for transmission to a dermatologist who then would formulate a diagnostic impression and suggest a treatment or management plan for the patient. And this plan may be formulated at a different time and place from the image capture. And we also see the same thing with capturing images of a retina, or capturing data such as blood pressure data or cardiac rhythms, et cetera, that may be then analyzed later by a provider. Another really important type of telehealth modality is remote patient monitoring and home telehealth. So this is the use of innovative at-home and mobile technologies to capture biometric data on patients, and the use of protocols along with a case manager that will help to monitor that veteran safely at home. And you'll hear more about this because this has become a key way that we help to really open up hospital beds during the pandemic by being able to monitor patients at home with this remote patient monitoring and disease management protocols. So these disease management protocols are a series of questions and answers, responses that are derived from routine clinical practice that kind of replicate the same type of face-to-face assessments that you may have. And it, again, along with the use of a care coordinator to help intervene should there be any types of information that look like they need to be acted on. Another important tool that was used a lot, and it has always been used a lot, and especially so in the pandemic, is MyHealthyVet. It's a secure portal that has over 5 million registered users, and veterans love using this for tracking their prescription refills, for either checking on their appointments to remind themselves when it is, or maybe to make an appointment, to send a secure message to their healthcare team, and to send that kind of exchange of information in a secure way, and also to view their healthcare records. So this tool really does help to put the veteran in the driver's seat and help them to be an active member of their healthcare team in driving the decisions made about their healthcare. Another really key important aspect of telehealth, and maybe one of the greatest opportunities for telehealth in healthcare, is the ability to bring clinical resources from anywhere in the country to where they are most needed. And when we're talking about disaster preparedness, this is a key aspect of telehealth. So the VA uses the capacity that it has anywhere in the country and telehealth to provide consistent, high-quality clinical services by increasing that clinical resource sharing between the different healthcare systems in our network. And this, as you may know, especially in a time like a pandemic, is key to having that consistent quality of care. The VA also has a really great resource in their clinical resource hubs. This is a series of regional hubs that act as a contingency resource for staffing by providing access to providers virtually, especially to cover where there may be needs. And we see this most often used in our rural and highly rural sites where it's so difficult to keep providers, and where it's a challenge both inside and outside the VA to have adequate healthcare coverage. So let's talk a little bit now about telehealth in VA's pandemic response. So telehealth really has been a key mitigation strategy in VA's response to the pandemic, and it has helped to increase access to care by leveraging all these different technologies. So initially, in fact, even before we had the first U.S. case, VA started on a very coordinated, aggressive response effort in planning that included the use of telehealth in that disaster planning. So basically, they were looking at using all of the resources that we had across our 18 networks and 170 medical centers to make sure that we could support each other through this pandemic. So we had that coordination at the national level, a National Emergency Management Coordination Cell that helped to make sure we were leveraging the best of all that was available. So one of the earliest things that was done, again, even before that first death of a patient in the U.S., et cetera, is to make sure that all of our healthcare systems were integrating virtual care in their disaster contingency planning. We also implemented a baseline standard of care for the surveillance of influenza-like illnesses and also a system for virtual resource utilization. So we saw this mainly occurring, or set it up to mainly occur at all points of the entry that included the telephone. So when they called in with signs of respiratory illness, that they could be screened and dealt with right there without having them come in and expose others or be exposed themselves. And so we do that at our kiosks when they check in at the entry point and other places. So we had this standardized baseline standard of care for that surveillance. We also established telework capability for high priority staff. And we did that by making sure that all the clinicians, especially those priority healthcare professionals, were able to deliver video telehealth from both their usual workstation and were telework capable in the event that a medical center was shut down, et cetera. So that did they have the equipment? Did they have the training, et cetera? So we were readying those clinicians to be able to work remotely. We also educated the veterans and make sure that they knew and did outreach on veterans on the topics and how to get information when there wasn't a lot of information out there already. So all of these were enterprise-wide plans that we had to leverage the capacity we had to support the surges in demand. So some of the tactics that we used early on to get to do the rapid expansion of telehealth services that was needed because of the pandemic were multiple fronts, actually. We did training and supporting both the workforce and the patients. We expanded the technology infrastructure, and that was both kind of behind the scenes in the VA in terms of our bandwidth and servers and all of that kind of thing, but also, as the little tiny picture shows, we also distributed tablets to veterans and increased the types of equipment that was available to hospitals to make sure that healthcare systems and veterans had access to technology when they needed it. We provided kind of that consistent messaging, and we built a plan to make sure that our high-risk patients had their needs met, and that includes the things like the development of the remote patient monitoring protocols, et cetera. So basically, we were expanding our capacity where we could to make sure that we had the capacity needed when it was needed. Most of the actual work of that, as you might imagine, really happened at the front line. So we had work from the healthcare teams themselves, both the administrative folks on the healthcare team and the support from the telehealth the team, and then we also had the providers. So all of our frontline clinicians and teams were ensuring that the veterans had what they need, and were able to make that transition as well to the increases that we saw in the use of telehealth. So there were really three priorities that drove our initial response. First of all, we had to continue to provide access to mental health care and to medical health care to millions of patients, and many of whom have multiple comorbidities, and they live in highly diverse settings. We had to prevent the spread of COVID-19 within our own facilities and keep both patients and staff as safe as possible. And we had to maintain or expand access in those COVID-19 hotspots and in states that were beginning to have stay-at-home orders. So we did that by the 4 work streams that you see on the screen here. So within Veterans Health Administration, the Connected Care team really worked on expanding telehealth to the home, supporting those veterans that were home in quarantine, and expanding our capacity and being able to support critical care. And this was a big shift that we saw in telehealth from an outpatient focus to an inpatient focus. So to utilize telehealth in an inpatient world, to be able to support where there was the greatest need during this pandemic, and then also strengthening those telehealth foundations, those less than glamorous things that have to happen around making sure we have adequate bandwidth and that the tools are as user-friendly as possible. So all of those work streams help to support the veterans during this pandemic. And these are the results. So prior to the pandemic, the VA was already providing large numbers of telehealth visits. As you can probably barely see at the bottom of this graph that kind of at the beginning of the pandemic, we were already providing over 10,000 video visits to the home or other non-VA site a week. But we, as you can see from the graph, that there was a rapid and kind of explosive increase in live video conferencing types of visits called VA Video Connect. And in fact, it was a 1,525% increase from March 1st to the end of October. just for the week ending on the 31st of October, VA provided over 180,000 VA video connect visits, with a peak number of visits in one day of 39,000. So it's kind of mind-boggling. But as you can hear from that, every one of those visits was a time that a veteran did not have to drive into a clinic and sit in a waiting room where either they are exposing other people or other people are exposing them or exposing staff or staff exposing them, and yet they got the clinical care that they needed. So imagine those are 180,000 opportunities to not be exposed to the SARS virus. So looking at our providers, we've also seen a significant increase in the percentage of providers who've completed training and have at least one VA Video Connect visit to the home and off-site. And we've seen this across our different specialties. So you might think, well, of course, in primary care or mental health, it makes perfect sense. But we're also seeing that kind of big growth in specialty care use of telehealth itself. Looking at the use of remote patient monitoring and home telehealth, you can see that the graph of the daily census of those patients that were monitored underneath the protocol for the high consequence infections basically has been following the same type of inpatient numbers that we see. So you see that same pattern of the graph, and that's not an accident. We are using remote patient monitoring and home telehealth to safely monitor our veterans at home that are either COVID positive or could have symptoms of it and could be, and especially if they are high-risk veterans. If they are low risk, we have other tools like the Annie app I'll talk about a little bit later, but especially for our high-risk veterans, having the ability to safely monitor them at home means that for those patients where they're trying to make a decision, should they be admitted, can they go home safely, et cetera, it gives them a safe way, if they can be safely monitored at home, an alternative to taking up one more hospital bed. And that really has helped to, again, increase access in our hospital where they actually needed those beds. So this slide is a favorite. Mr. Navielli is a veteran that is grateful for VA telehealth remote patient monitoring that helped to monitor him, and has an interesting story. He was actually discharged from the hospital and doing well at home for a while, and felt relatively okay, but his case management nurse picked up on the fact that she did not like some of the trends of his vital signs and sent him back for an evaluation, and he's claiming that intervention saved his life. So we've heard many other stories, and psychologically, our patients really loved having the reassurance of being monitored at home. And it's been a high source of patient satisfaction. We've also seen this same reaction to the Annie app that we have, and the coronavirus precautions protocols we have on our text messaging platform is basically a way to send automated text messages to veterans on to help them monitor their symptoms and advise them on when to contact their healthcare team or a nurse triage line. So we've seen a lot of growth in the use of that, as well as another application that was sent out to help with coping or mental health resilience during COVID. So providing motivational and educational messages to veterans who are kind of struggling, as aren't we all, with the stress during this COVID-19 pandemic. So both of those applications have seen a lot of use and growth and have served as a source of support to our veterans during the pandemic. Another, probably one of the most important uses of telehealth in the VA during the pandemic has been the national expansion of Telecritical Care. So this is where we're providing remote monitoring of ICU patients and giving access to bedside clinicians, to experts in critical care, intensivists and nurses who are ICU nurses, and allowing them to have a consultation if they need it. So it uses mobile telecritical care carts at the bedside software to provide this two-way audiovisual communication where the bedside clinicians can speak with the expert consultant, and the expert consultant can also visualize the patient and the monitors and everything going on with the monitors. They can also remotely just monitor what's going on and alert the bedside clinicians if something is triggered and it appears that it needs attention. So this national expansion of Telecritical Care was centrally funded, and that helped us to get out the equipment and provide the software and those mobile telecritical care carts throughout our healthcare system to any sites that had ICUs, and to provide access to that two-way audiovisual communication if needed. As you might imagine, this is especially important in those smaller facilities in rural locations. So with all of this, so the ability for us to connect to the veteran wherever they are and really whatever the circumstances has allowed the VA to provide care for veterans at a time where it really was needed, and it also allowed us to support externally over 65 FEMA missions and 93 FEMA task teams across 45 states. And we saw a lot of that, those mission assignments include places like nursing homes, state healthcare agencies, Indian Health Services, and other types of facilities. The VA also accepted patient transfers from state and local facilities that were running out of beds themselves, and so there was a lot of support that the VA provided under what is called our fourth mission, and to serve as that backstop or that safety net to the U.S. healthcare system. So I talked a lot about the VA's experience. So what can you take away from the VA's experience with the use of telehealth during a pandemic? So for government agencies and communities and healthcare systems, many of which are on this call, I think the biggest takeaway is the need to make sure that your disaster and pandemic response plans are leveraging telehealth. So are there services there that are most likely to be overwhelmed that could be provided by telehealth? So identifying those services and identifying what the resources are in your area that could be assisting. Again, it's that idea of bringing capacity where it may exist to come to the aid of a place that's overwhelmed. So mapping out what that would look like, the virtual disaster response processes, tools, and workflow. The devil's always in the details, right? But you'll have to basically make sure that that what's in your plan can support that, and that you've got those virtual volunteers in your disaster response assets, that you have access to that information, technology infrastructure and support, that you've included vulnerable populations in your plan, and how you can use telehealth for those proactive outreaches. And I think the last most important thing for government agencies and communities is to make sure you're supporting initiatives that reduce the digital divide for those who don't have consistent access to telehealth modalities. So we talked earlier in this discussion about those basic needs for bandwidth, for access to the internet, et cetera, and especially in highly rural areas, it's very important that that is a big part of the plan to be ready for a disaster or a pandemic, is to make sure that all of your citizens have access to the basic needs to be able to have a telehealth visit. Now, you may not have been aware before this discussion of all the ways that technology can be used to support your healthcare needs. I encourage you to think about your own personal plan, your own personal telehealth options, and ensure that your personal disaster response plan does include telehealth. I know for me as an individual, my physician did not even offer telehealth visits until I think about March in the pandemic. So just get familiar with that telehealth services available from your own healthcare team. It may be available now if it wasn't before. Learn how to access that and any other information on your healthcare, like your medications, et cetera, that in case you had to evacuate in a hurry and you need a refill of your prescription. Take advantage of the tools that are out there. FEMA has some fantastic support tools, including their app that I have on my own phone that will give you weather and emergency alerts. There are brochures that we've all used here at the VA for helping with our vulnerable populations to make sure that they're preparing for disasters if they have special needs. So take advantage of all of those resources that are out there. Make sure you've got that cell phone charger in your emergency go kit, and go ahead and, if you can, make your next healthcare visit a telehealth visit, because then it won't be one more new thing to do during a disaster or emergency. So make sure you're taking advantages of all those resources out there and when needed. So thank you for this opportunity to share an overview on telehealth and the value of optimizing the use of telehealth when responding to disasters and emergencies. Now I'll turn it over to Bill England, a Senior Advisor for Telehealth with Health and Human Services, to describe telehealth and Health Resources and Services Administration.
Bill, are you on the phone line?
Yeah, Bill, if you're talking, we can't hear you.
He's
Well,
typing,
Debbie,
so give us a second.
Okay, great. Well, while we're waiting for Bill to join, are there any questions that you'd like me to cover?
Actually, there is, Lori, if you wouldn't mind.
Sure.
One of our listeners asked if you wouldn't mind elaborating a little bit more on the training provided to vets who may not be familiar with technology, or maybe they don't have technology, and those who have special, unique needs such as Alzheimer's or brain injuries, or maybe just an older population. Do they get support from the MMU, local VA offices or hospitals? How does that work?
I'll tell you how it works at the VA. So they do get support. They can get support from their frontline PAC team who might walk them through. And we also have a program now to do kind of a supervised test visit ahead of their VVC visit. And so that will help the patients with their training tools. Plus, we have online support and written information that they can access as well. So there is that support, and it's interesting because we have an older population on average compared to the rest of the country, and yet we find that our older veterans love the technology, and they get used to it very quickly. So I think that there is definitely a need to be thoughtful about that and to provide lots of hands-on care, for veterans. So we have a help desk that they can call. We have training materials, and then also a new program that's really recently started up where we're using college kids mainly and volunteers that are tech savvy to assist veterans with that test call. So does that answer the question?
I believe so. Thank you.
Okay. You're welcome.
I also believe that Bill has joined us, and if he could unmute himself, then we could get started on his portion of the presentation.
Okay, I believe I'm unmuted. Are you hearing me?
I can hear you.
Great.
Speak a little louder, please.
I apologize. I jump back and forth between platforms and forget which ones I have to use a separate call-in for.
No worries.
So thank you very much for the opportunity to present today from HRSA. We have in the Office of the Advancement of Telehealth in the Federal Office of Rural Health Policy been doing telehealth since the late 90s. We are delighted to have so many new partners involved in telehealth, and the VA has certainly been one of the partners we've had some work with for many years. Their program is always very large and very innovative, and we try to adopt some of what we learned from them to our more civilian programs, largely Medicaid oriented. But as a result of the pandemic, we have lots of partners we had never worked with before, and lots of opportunities to talk about what we do as well as assist others. And we're doing our very best to keep up with all of it. And I hope I can leave you with some of the resources that we can contribute to some of the newer folks that are involved in telehealth. As Lori mentioned earlier, standing up a new telehealth program when you weren't doing it was a bit of a challenge in March and April, and as was mentioned, my first telehealth actual visit with my provider did not go well at all. We had technical failure, but it was a very good experience for me to see what it's like when people are new to telehealth and trying to get started. So we've done our best to help with that. If I could jump to our next slide here. HRSA's program is dominated by health centers. Health centers serve about 30 million people, largely on Medicaid or other federal assistance programs. My office in the Office of Rural Health Policy is much smaller slice of the pie. We are very focused on telehealth, but the actual HRSA activity in telehealth, because of the size of the Bureau of Primary Health Care being almost half of all of HRSA, there's more telehealth there than any place else in HRSA. Just in terms of our budget, we are largely a grant-making organization. The blue lines, meaning these are discretionary grants that we're funding. We do have mandated programs as well, which are growing in our almost $12 billion budget. We also, under the CARES Act and other programs, had quite a bit of funds that we distributed to providers directly appropriated from Congress. One of the things I want to leave you with, if you are a telehealth provider that is eligible for one of our grant programs, which is nonprofits and in some cases for-profit entities, you should be visiting grants.gov. As I mentioned, we're a grant-making organization. That's how we get our money out the door. So grants.gov covers all federal agencies putting things out that the public can seek funding under. If you simply type telehealth in the search function at grants.gov, you'll come up with all the agencies and what their open opportunities are. I did that a few weeks ago for this slide. I think there's about 4 that were HRSA and about 6 or 7 that were non-HRSA grants that cover telehealth. We encourage project officers to be sure and put telehealth somewhere in the abstract or keyword or something in their funding opportunities to make sure that it pops up when you search grants.gov. This just a quick snapshot of what's going on at HRSA in telehealth. Back in 2017 was the first time we knew there was a lot of telehealth going on throughout HRSA, not just in my office, which was totally devoted to telehealth. We did our first look in 2017, found we had 1,000 of about 5,000 grants mentioned telehealth. We're now up to over 1,800 of our grants mentioned telehealth, and that's for 2019. I think we'll discover when we do this next year, because of the pandemic, that almost every component of HRSA has a lot of telehealth. The largest single component, as I mentioned earlier, is the large red bar is the Bureau of Primary Health Care, which is our health center or FQHC program. Focusing just on that one, as I mentioned, 30 million patients are served by health centers, 400,000 veterans in reference to what Lori just presented. This is a program for a lot of people. About 40% of health centers indicated they were using telehealth prior to the pandemic, although we didn't have a good indication of how much they were using it, simply that they knew what telehealth was and were doing some telehealth. As a result of the and our data source for this always comes in about a year after the fact. So this is looking at 2019 data pre-pandemic. And during the pandemic, as a result of the pandemic, under the CARES Act, we received about 46 million for HRSA programs specifically devoted to telehealth. And we distributed those funds to maternal and child health grantees, to some of our telehealth resource centers I'll talk about in a minute, to licensure portability work we're doing to do cross-state telehealth, and to provider training. So these funds have already been expended for those purposes. With regard to veterans specifically, looking at our 400,000 veterans we serve in health centers, that's only about 1.3% of our total service population, but it varies a lot by state, from less than 1% in Nevada to almost 6% in Maine. Matching that to where we have the most telehealth in health centers indicates that Alaska is probably the biggest user of telehealth for veterans, followed by Montana and Maine. While we know how much telehealth is going on and we know how many veterans we're serving, what we don't have in our data collection is the ability to know whether telehealth is specifically serving veterans. So we'll leave that to our colleagues in the VA to actually focus specifically on telehealth for veterans. So as a result of the pandemic, we knew we had to stand up telehealth very quickly in service to our 30 million beneficiaries. The 1,000 health centers that reported to us, we began a weekly survey, voluntary survey, so not all of them are reporting. But on the 1,000 that did report, all of them said they're using telehealth, with about 51% of their total visits being telehealth, ranging from 18% to 88%. I think 88% was New York. If you remember back in May, we were having the height of the pandemic hitting very much the East Coast in New York. In some of the western states, we're only a small 18% telehealth. By July, that average had dropped to 34%. Most recently, looking at it, it was down to 27%, with about 5% of our health centers saying we're no longer using telehealth. So the real question is, what is the curve going to look like? What's it going to end up at? And nobody knows the answer to that. We're seeing this this is actually looking at Medicare claims. It hit a peak in May and early June, and now the telehealth visit component is beginning to drop, and this only goes through, for example, July. The rural use of telehealth is much higher than urban, which is not a surprise, but we'll see this begin to decline, and we don't know where it will end up. It's certainly going to end up much higher than we were pre-pandemic. Patients really like telehealth. This is a tool we've had for many years, Find a Health Center. For our 30 million people, we map where you can find a health center that will accept you regardless of ability to pay, or will help you make sure if you're qualified for Medicaid to get you enrolled in Medicaid. So these are the last stop healthcare providers that we operate. And you can go to a map and find where's the nearest health center. During the pandemic, I think around July or June, we added telehealth. So all of these circles that have something inside of it, a little X, are health centers that offer telehealth. The ones that don't have an X means they don't offer telehealth, but you can see most of them do. And anyone can go into this map and say, where can I get telehealth from my nearest health center? Telehealth is not new. As I mentioned, we've been doing telehealth in the Office of Rural Health Policy since the late 90s. But in fact, even as early as 1924, before we actually had any commercial television, it was just in laboratories, people were already speculating that we could start doing house calls using telehealth. They called it the radio doctor back in those days. And they actually had a lot of concepts correct. But of course, the technology was not available and was way too expensive. And even back in the 90s, when we first started getting into this, it was much too expensive to consider people actually using it. Well, times have changed. Everyone, or many of us, have smartphones. Now the issue has become not the cost of the technology so much, but do we have broadband? In some of our rural areas, we know that broadband is lacking, and there is not the ability to go direct to consumers with smartphones that don't work well in some of our most frontier areas. So we're working with FCC and other components to say, how do we get this broadband to everyone that may need it? And also, we're trying to figure out how much home visit telehealth is going to continue once the pandemic is over. Moving specifically to our programs, we have 6 programs we're funding in the Office of Advancement of Telehealth that are 100% devoted to telehealth. The Telehealth Network Grant Program, where we're actually delivering telehealth services. There's 2 versions of that. One is mostly focused on delivery. The other is focused on delivery, but also fairly data collection intensive to those grantees. So we learn about how telehealth is working using controlled studies, controlled trials, and control groups. The telehealth resource centers I will really focus on, because that's one of the takeaways I need to leave with you that will help you with telehealth programs you may be running. The telehealth-focused rural health research centers, where we're actually funding research on telehealth. Our license portability grant program I referenced earlier, trying to solve the multi-state practice of telehealth problems. And then 2 centers of excellence that are test beds for telehealth in Mississippi, University of Mississippi, and University of South Carolina Medical University. Moving to the next slide. So the telehealth resource centers. A resource center is assigned to every state in the country. There are 12 regional centers. there are two national centers. One of the national centers focuses on technology, one focuses on policy. If you go to telehealthresourcecenter.org, you will see this map. You can click on your state. It'll take you to the resource center serving your state, or you can click on the policy or technology centers that serve the entire country. The purpose of the resource centers that we're funding is to help provide information, webinars, conferences, guides, and fact sheets, anything people need to know about telehealth, largely focused on providers of telehealth. They did a land office business. Their business increased about 1,000% at the start of the pandemic, and that we did supplement their funding so they could keep answering the phones, answering questions. They are essentially a technical, consulting service that will help you with your programs with us paying the cost. Now, they can't actually write grants for you or actually design your program in great detail, but they will answer your questions. If you need a lot of help from them, they may have to ask you for setting up a contractual arrangement. But at least for basic questions you have, just call them and they will get back to you and answer questions. How do I deal with licensure? How do I deal with reimbursement? How do I deal with planning a telehealth? How do I do scheduling? They are experts in all of this. The two national centers, the Technology and Policy Center, the Technology Center has toolkits. They don't recommend specific vendors by name, but they will help you figure out what do I need to ask vendors if I'm buying cameras, I'm buying microphones, I'm buying routers, I'm buying telehealth equipment, home monitoring equipment. They have toolkits for all of these things, videos you can watch, how they demonstrate how they work, and they'll help you, if you're working with a vendor, help you figure out how to get best value for your investment in telehealth. Likewise, the Policy Center, huge number of policy issues. So many of them changed during the pandemic. We are under emergency measures, reimbursement, licensure. Many things are completely different under the pandemic. We have a website specifically devoted to all the changes that took place in policy during the pandemic, and I think I have a slide on that in a second. As I mentioned, webinars, they conduct several webinars a month. All of them are recorded, so you can come back and watch them later. We just had an excellent webinar on Tuesday on having a nationally known attorney physician talking about licensure and some of the issues you need to deal with in telehealth. That's actually a two-part series. You can watch the video. We keep videos going back about 5 years, so you can go to the whole library of webinars that we have been conducting and on different topics each month. And as I mentioned, the toolkits at TTAC can help you with planning for technology. There's a COVID site. We specifically took all of our resource centers, rather than having all 14 and put stuff up about COVID, we segregated all of it into a COVID site, trying to focus on and keep up with all the changes from CMS, all the changes from the Department of Justice with regard to HIPAA and licensing requirements, where there are some requirements that have been waived in order to facilitate telehealth under the pandemic. So we housed all of that in our COVID-19 website that is part of the National Telehealth Resource Center website. A new website was also created by the Department of Health and Human Services, our telehealth website, telehealthhhs.gov. We went out and largely borrowed from our telehealth resource centers that we were funding as grantees for a lot of what we initially put up, but we've been since populating this with every federal resource we can find relative to telehealth to try to make this for the federal agencies somewhat of a one-stop shop to house anything we or you want to put up related to telehealth. We divided it into a patient side and a provider side, and in particular, our telehealth resource centers had really been focused more on providers than patients. So this is, we would like to think, the best opportunity for patients to understand telehealth. We have on our telehealthhhs.gov website resources for patients, introductory videos, and information patients may need to know about starting their first telehealth visit or even finding telehealth providers. That side of the website is entirely available in Spanish as well. We're considering what other languages we may need to get up. The provider side does not have the Spanish opportunity. This is an example of, we have a lot of videos up, understanding telehealth. This is Telehealth 101 for patients to see what their first telehealth visit is going to be like before they actually engage their provider. On the provider side, we get a little more technical with topical searches for things providers need to know. As I mentioned, a lot of this does actually reference the Telehealth Resource Center sites, we check with them regularly to see what they have put up. We take some of what they put up and then put it up on our site, but we also reach out to federal agencies and put up other things that may not be showing up on the Telehealth Resource Center site. In particular, the federal government can't reference specific vendors and endorse things, and we put a disclaimer up. We're not endorsing anyone, but we do have links to a couple of sites that do name specific vendors. The Telehealth Service Provider Directory, which is housed at the University of Arizona and one of our Telehealth Resource Centers, and then the Digital Health Directory from the Consumer Technology Association. These do have specific named vendors and links to reach them. We're simply linking you to those sites, and we don't endorse any of the vendors on them, nor do we decide who is on those. It's up to the individual agencies, the individual entities that run those sites. One thing I want to close with, the Lifeline program, the Universal Service Lifeline program, has been an extremely important part of response to COVID. This is a program that's been around for a long time, provides low-cost or no-cost cell phones, and now pretty universally these are smartphones that are very capable of doing telehealth and provide low or no-cost connections for people that qualify, meaning you're on a federal assistance program of some sort. This, in our telehealth programs, we have, until COVID, largely been focused on connecting providers, connecting rural providers to urban specialists, connecting rural hospitals to urban medical centers, to use technology to take high-powered urban healthcare to very remote rural providers. But we haven't been focused on direct-to-consumer. But under the pandemic, that has become the main issue, and as I mentioned, we've discovered broadband can be a significant impediment. Also, the technology can be an impediment. So this program that provides phones and highly discounted services to qualifying folks is very important to us. We don't run it. We simply send people to the FCC, to the Universal Service Program. But if you're not aware of this program and you're serving people that may not have smartphones, by all means, check out this program. That concludes my presentation, and I'm happy to take questions or have Lori respond to more questions. So I will now take a quick look at the chat. If you
Bill, I will. I'll read off the questions for you and Lori. Okay.
Yes.
Okay. And the first one is for Lori, but I think it's probably applicable to both. So one of our listeners was asking what cybersecurity measures are in place to protect, all of this very sensitive personal information. And from your perspective, are there additional measures that you would like to see in place? Lori, do you want to start?
Sure. So for the VA, all of our telehealth tools are securely behind a firewall, and we have entire teams of people whose only job is cybersecurity. So I think that's a great question, because it's an important topic to make sure that our information is secure, and especially in the video conferencing world. I think early in the pandemic we saw a lot of external healthcare systems utilize platforms that were not secure. But for the VA and our tools like VA Video Connect, they are securely behind our firewall and have all of those cybersecurity aspects in place. And Bill, your thoughts?
Yes, and as you mentioned, because of the waivers that took place at the beginning of the pandemic, and because a lot of new people got into telehealth that hadn't been in before, using a variety of platforms, some of which were less secure than others, but necessary simply to get care to patients, there probably were some increased risks that took place, and I'm not sure we necessarily know all the fallout. That's really not something that we have been actively involved in because we're simply funding grantees. We do expect them to be aware of and procure appropriate platforms with appropriate security. We're discussing now how involved HRSA might want to get in the security issues as we're beginning to know that there are some challenges that newbies to the program may not be fully aware of. So we don't have direct involvement in cybersecurity, but we are certainly paying attention in talking to folks at the Office of the National Coordinator and other parts of HHS that are very focused on cybersecurity. So more to come on that.
Thank you both. I don't know that this is a question as much as it is a comment, and I did hear Bill mention this, but, you know, Lori mentioned rural communities, and the lack of broadband in rural areas unfairly excludes this segment of the population. So what is being done to ensure that this segment is included in this technological advantage for the future?
As I mentioned, you know, Lifeline is an important component, again, because HHS or HRSA is not a funder of broadband. There's really limits of what we can do other than pointing people to programs such as the FCC, Universal Service, USDA that do fund broadband directly, and trying to keep aware of what they are doing and how we may be able to publicize it.
And I would add that, I'm sorry, go ahead, Lori.
Oh, thanks. So I think this is an excellent question because the digital divide or those social, economic, and geographic barriers to telehealth have to be solved as a community, and it goes well beyond what any individual agency like the VA can do. However, what the VA is doing about the digital divide, we recognize that this is a huge issue, and we've done many initiatives to try to help with that. One of them is we've implemented a consult called the Digital Divide Consult, where a clinician can refer a veteran that has one of these social, economic, or geographic barriers to a social worker, and they work with them to see if they qualify for programs like Lifeline, or they may qualify for our tablet initiative that helps to distribute. So far, since March 1st, we've distributed over 7,000 tablets we've loaned to high-risk veterans with access needs. We've also partnered with external partners to help provide things like discounts for these services, telehealth services, and also that if you have certain types of cell phone carriers, that they won't charge you for your video conference data time if you're having a VBC visit with your VA provider. So we are actively working on all those things that we can control within the VA, but also I think this is an important topic that should be continued to be raised at every opportunity, because it is going to take all hands on deck to address all of those barriers, such as the lack of access to broadband in highly rural sites. So thank you for that question.
And I was just going to add that we are planning to have a broadband webinar discussion coming up in 2 parts in February and in March, and they really do need champions for broadband in these communities. The next question we had was whether or not there was some information related to telehealth in Puerto Rico being one of the 4 states represented in Region 2.
So although if you go to our Telehealth Resource Center map, Puerto Rico is not showing on that map as assigned to a region. It is assigned to, informally, to the Southeast Telehealth Resource Centers. But if you simply call our Telehealth Resource Centers and ask for who's dealing with Puerto Rico, we'll get you there. In our next round of funding, Puerto Rico, we actually, which is on the street right now, Puerto Rico is explicitly mentioned as part of what has to be covered by our resource centers, but we're informally doing it now.
Okay, good. Thank you, Bill. How does telehealth work when it comes to like blood draws, urine and stool samples, lymph node exams, optical pressure tests, etc.? How does that work?
So this is Laurie.
Yeah.
And, I'm happy to weigh in on that one. So not every type of healthcare service can be done by telehealth. Many things can be done, but if it requires that hands-on care, then there are parts of it that may have to be done hands-on. So, for example, if you have a video visit with your provider and they want to have some labs drawn to check on a certain organ, then they would refer you. They would use telehealth to put in the order, et cetera, but you would have to physically go and get your blood drawn. So not 100% of every type of healthcare service is appropriate for healthcare, for telehealth.
We are finding, as a result of the pandemic, some very creative people that are expanding telehealth in ways that previously weren't being done, and what we're trying to do is capture all of the innovation in telehealth to figure out exactly what is the best uses, the best practices for telehealth. So I think we'll see a lot more types of telehealth post-pandemic than we've had in the past, but absolutely things that require hands-on. For example, teledentistry is one of our fastest growing areas. Now, how the heck can you do teledentistry with telehealth? Well, what that really means is we simply have the ability to use a high-resolution camera to have people or family take pictures of someone's mouth and really make a decision. Is it important to come in and get this dealt with, or is this something that can wait? So very creative things going on, and we'll try to capture that as best practices.
Yeah, and if I could just share a quick, short little story. I woke up a couple of weeks ago and I felt like I had a golf ball in my throat. So I called my doctor's office and I said, well, I'm sick. Oh, you can't come into the office. I said, but I really think I have strep throat. I need a throat culture. Oh, I'll schedule you for a telehealth visit tomorrow. I said, I need someone to look in my ears and to swab my throat. How are they going to do that over the phone? Oh, I don't know how they do things. So even their own offices are having a hard time, I feel, figuring it out. When in turn I was able to pick up the phone and call urgent care, and they said, oh, sure, no problem. Drive your car up to the cone, go under the tent. They looked in my ears. They swabbed my throat. They swabbed my nose. I was out of there in 10 minutes. It was the best office visit I ever had. And within 2 hours, I knew that I had strep throat, and I had antibiotics called into my local pharmacy. I mean, that was efficient. I wish it could always be like that. But the point of the matter is that they're still figuring it out, a lot of them. Do either of you happen to know if there is an optometry telehealth exam that could measure vision? Do you know that if anybody's been using that?
So teleoptometry has been around since, again, the 90s, and we see things like, kiosks put into a location where an optometrist or an ophthalmologist will connect, and it's simply operated by a patient looking into devices. We haven't had a lot of discussion of that recently, but yes, it is pretty amenable to picking up a variety of things that you can, such as diabetes and searching for diabetic retinopathy. So yes, I don't have a specific reference, but on our telehealth resource centers, if you were to type teleoptometry, I can guarantee you'll find hits and references to learn about it.
Okay, if I could just ask that.
Oh, just to weigh in, the VA has a very busy tele-eye program as well, so Bill's right. There are a lot of uses